Well, good evening, ladies and gentlemen. Great to see you all here. I'm Mike Brooks. I'm the Deputy Vice-Chancellor of Research here at the University of Adelaide. Can I first acknowledge the Kaurna people, the original custodians of the Adelaide Plains and the land on which the university's 4 campuses are built. Welcome everyone to tonight's Research Tuesdays event and our second inaugural lecture for the year. As many of you would know, this year's Research Tuesdays program is incorporating a series of inaugural lectures, and these are held to mark a major milestone in our researchers' careers, such as achieving the rank of professor, or in tonight's case, being appointed to a chair in the university. Tonight, I'm delighted that we welcome Professor Alastair Burt, who is Executive Dean of the University's Faculty of Health Sciences. Professor Burt began his career overseas, graduating from the University of Glasgow and then moving to the University of Newcastle in the United Kingdom. At Newcastle, he held several senior leadership positions as postgraduate subdean, head of school and dean of clinical medicine. He was also the inaugural director of the Centre for Liver Research. He has a long-standing interest in medical education and contributed substantially to curriculum redesign in the medical program at Newcastle. In January 2013, he took up the role of Dean of Medicine at this university, and in December 2014 was appointed Executive Dean with oversight of the Faculty of Health Sciences. He was made a Fellow of the Australasian Royal College in 2014. He's published extensively on the pathology of fatty liver disease and autoimmune liver disorders, in addition to basic and translational studies on liver fibrosis. Alastair is Editor-in-Chief of McSween's Pathology of the Liver and Editor-in-Chief of the peer-reviewed journal Histopathology. Would you please join me, with some trepidation perhaps, in welcoming our speaker, Professor Alastair Burt. Thank you, Alastair.
Thank you very much, Mike, for that kind introduction. And thank you all for coming along this evening. I was actually originally scheduled to give my inaugural lecture back in November, I think it was, of last year, but that had to be postponed. So I'm delighted that I was asked to contribute to this year's Research Tuesdays. I'm going to talk tonight about diseases of overindulgence. Given that it's an inaugural lecture, however, I'm going to start by saying a little bit about myself, why an interest in liver disease, and then say something about the archetypal fatty liver disease, alcoholic liver disease, and then describe the understanding we now have of a range of disorders that are not alcohol-induced, but caused by other forms of excess, but give rise to the same spectrum of disease. So we refer to that as non-alcoholic fatty liver disease. And we now recognize that that is a problem of quite considerable emerging public health significance. One of the areas that I've been particularly interested in is the importance of us having accurate diagnosis of the fatty liver diseases by applying clear definitions and a firm classification. And that's going to be important in understanding the epidemiology of the disease, particularly non-alcoholic fatty liver disease. And I'll describe what I mean by that in the course of the lecture. But Mike already indicated that some of my interests have been in translational studies of liver fibrosis. Fibrosis is another name for scarring, and liver scarring is something that occurs at the latter stages of fatty liver disease, but also in really all chronic liver diseases. And over a number of years, I've been interested in how this liver scarring occurs, and more recently, how we can use that information to understand how we treat the disease and limit the scarring, and in addition, better and safer diagnostics. So, what about myself? I hail from the ancient capital of Scotland. That's Dunfermline. This is Dunfermline Abbey in the photograph here. I then finished my schooling in Glasgow, and as Mike has said, I went to medical school at the University of Glasgow. I went there at the tender age of 17. And for the first 2-3 years, I was absolutely sure I was going to be a surgeon. And in the curriculum there, we had the opportunity to spend a short period of time, an elective period, in a hospital of our choosing at the end of third year. And I chose to go to a small country hospital in Ayrshire, which is Robert Burns' country, at a Ballochmyle hospital, and Ballochmyle features in some of Rabbie Burns' poems. And there I worked with a surgeon, a delightful chap, who took out gallbladders in the morning and tended his sheep in Ayrshire in the afternoon. And I actually thought, yeah, that's a great life to aspire to. But I also thought in the course of that elective that I wanted to spend a little bit more time in the science of medicine. So the very last day before I was due to enroll in fourth year of the medical program there, I approached the professor of pathology to say, look, I know I'd said no, I wouldn't do one of these honours programs, but would you admit me? And so I was very fortunate that they did take me on. It was a 2-year program and probably 2 of the best years of my life. So this is the fresh-faced young student in University of Glasgow. And while I was doing the honours program, I worked with 2 inspirational supervisors. One with Rab Gowdy, the Glasgow Royal Infirmary, where I worked with him on thyroid cancer. But I particularly am indebted to Sir Roddy McSween, who was my main supervisor, and with whom we carried out some work on the immune system in alcoholic liver disease. The concept being that some patients with alcoholic liver disease may get the end stage of the disease because their body is reacting against their liver, not just that it's the alcohol. And so we published an article on that. Actually, it came out shortly after I had qualified in medicine, but that was a real first proper taste of medical science for me. I returned to the medical program, and a number of other subjects interested me. I was very interested in obstetrics and psychiatry, actually. And as is the case in this country, I had to do a 1-year internship. And during the course of that, I was reflecting back on my experience with Sir Roddy and was pretty sure I wanted to do something with the liver, whether that was as a surgeon or a physician or indeed as Roddy as a pathologist. I actually decided I was going to do the physician training, and I applied for the rotation in the west of Scotland, and one afternoon got a phone call from Sir Roddy saying, "What's this? I hear you've applied for the physician training. Don't worry, I'll get you a job in pathology." And indeed that was created. You can't do that sort of thing nowadays, but it was created, and I never looked back. I had no regrets in pursuing that path. And when I did go back and start my postgraduate training with Sir Roddy, I started right away in getting involved in research. And again, we were doing quite a lot of work around alcoholic liver disease, and we described a number of lesions in the liver under the microscope in alcoholic liver disease that hadn't really been described previously. And they're not common, but they do contribute to the advancement of the disease. And again, fresh-faced young postgraduate. Note that I'm the only one without a jacket. I don't think I could afford one in those days. Things have certainly got better. Now, during the course of my training in Glasgow, I was given the opportunity to do a fellowship abroad, and I went to work with Eddie Wisse in the photograph here at the Free University of Brussels. And that was more basic cell biology. We were looking at the capacity of some cells in the liver. They're called Kupffer cells. It doesn't really matter what they are. And they were, I was looking at their production of a protein called complement. And again, it doesn't really matter what that is. In fact, it was all a bit dull. And yes, these cells produce complement, but so what? But what was more important is that during my time there, I worked with a chap called Burt Geertz, and he was getting interested in liver scarring, liver fibrosis. And I did a lot of in vitro work with him, which complemented work that I actually had done immediately before that in Glasgow, which I'll describe later. While I was in Belgium, I also continued with my training in histopathologist as a clinical histopathologist, but again, principally around the liver with another great mentor, Valère de Smet. Now, one of the things that was particularly pleasing to me as a student in working with Surrogate was that I got to proofread the very first edition of a book called The Pathology of the Liver, which wasn't the first book on histopathology of the liver, but it was the first that actually tried to be quite comprehensive and really cover the whole spectrum of this area. And that was such a privilege as an undergraduate student doing my honours year. I got to learn so much by doing that. I also got to learn a lot about writing because Surrogate was originally from the Western Isles and his first language was Gaelic, and actually as a consequence he was a particularly pernickety and good editor. I subsequently, when I went on from Glasgow to Newcastle to take up the role there, became a co-editor of this book, and we've now called it McSween's. Roddy's now retired, but it's now into its 6th edition. In fact, the 7th edition is now well underway. And it is comprehensive. Indeed, the marketing for this says, if it's not in McSween's, it's not in the liver. Now, I need to say a little bit about what the liver does. I'm sure that many in the audience know a bit about this. But when asked about what the liver is there for and why I'm interested, I always say that it's because it's really metabolically one of our most active organs. It really does a hell of a lot. And the two big areas are that it acts really as a factory, producing a number of key components of our blood, for example. So our clotting factors and a protein called albumin are all produced in the liver. At the same time, it's really a bit of a refuse site. It's where we break down a number of waste products from our general turnover of cells and of hormones and so on. So that includes, for example, pigments that derive from when we break our red blood cells down, which happens in our body all the time, and ammonia, which is something that is generated by bugs in our gut, and the liver's there to actually clear that, because if you don't, it goes to your brain and makes you all fuzzy and so on. So the liver is a really, really important metabolically active organ. And I'm going to show you some slides later, which are microscopic slides. I'm not going to show you those in detail, but I need to just explain that the liver, like other organs, is made up of cells. And these cells, some of them are linked to one another. And the main cell that does all the action, the factory and the refuse site, is the hepatocyte. That's the main liver cell. So our liver, the bulk of the liver, is actually made up of these cells. The way that they do their business is that between lines of these liver cells, there are small blood vessels. And in the liver, these are called the liver sinusoids. And the liver sinusoids bring blood from the gut through the liver, and while it's going through the liver, some of the building blocks from foodstuffs in the gut, called amino acids as one of them, they then are transported to these liver cells. They then use those as part of that factory function to produce the proteins that we need in our blood, and they then export them back out into the blood, and it goes all the way along the other direction. So that, in a nutshell, is what the liver is there for. But why else might I be interested in it? Well, one important aspect is that liver disease is very, very common, and getting commoner in many countries. And I'll show you this graph here. This is actually from the UK. The lines on this graph are the relative rates of death from different diseases. So it includes some forms of cancer, diabetes, stroke, and you'll note that actually some of these are pretty stable. Indeed, some are going down. So in the UK, ischemic heart disease, relative rates of death from that are going down. These are all relative figures. Relative rates of death from liver disease are in this spectacular upward curve. And in the UK, we know that quite a bit of that is alcoholic liver disease, particularly in my home Scotland and Glasgow in particular. But we also know that some of that is because of other liver diseases, and particularly what I'm going to be talking about, non-alcoholic fatty liver disease. Now, when I was training with Sir Roddy, by that stage we already knew that alcoholic liver disease had a spectrum of changes, and if you stuck a needle into the liver of patients with alcoholic liver disease, depending on how long they've been drinking for and how much they've been drinking for, they might have a different set of pictures down the microscope. And the first form is just simply that in those hepatocytes, those important liver cells, you get accumulation of fat. So the liver becomes bigger because it's got a lot more fat in it, and the fat is in those liver cells. Then in some patients, in addition to the fat, the liver cells begin to disintegrate, and you get inflammation, just like the kind of inflammation you get in the skin. That in turn then leads to some of that scarring, that fibrosis, and as a consequence of that, there is the possibility of moving on to a stage called cirrhosis, where not only are all the liver cells injured, but there is scarring, and the scarring forms around nodules of preserved liver cells. And those nodules are important because actually that inhibits the flow of blood through the liver and causes other complications. And in some patients who go through this spectrum, there is a risk of liver cancer. So that is the spectrum well recognized for many years. Now, this is on the left here, a photograph of something down the microscope, and these things here, these pink square things, are the hepatocytes. Each cell has a nucleus where all the gene material is, and the purple dot in these is the nucleus. So these cells over here are pretty much normal liver cells, normal hepatocytes. These over here, however, are stuffed full of fat. And if you take a liver out at operation, at transplantation, for example, when it shows this down the microscope, that's what it looks like. Greasy, yellow, very unlike what you would normally see as liver in a butcher shop, for example, which is a different color and doesn't have that greasiness. So this is absolutely full of fat. Now, it's very important to note that this accumulation of fat is highly reproducible. So there were some studies done in the 1950s in the US that you would never get away with nowadays, but medical students were allowed to, encouraged to drink over a couple of weekends, I think it was, but they had to then get a liver biopsy. Now these were students that hadn't been heavy drinkers previously. They were students, so that it wasn't that they were completely abstinent, but they were not heavy drinkers, they were not chronic alcoholics, and all of them got this in the liver. So we know that just simple alcohol metabolism can do this if it's to excess, even over a short period of time. But we also know that that's entirely reversible. So if you stop drinking in that sort of way, then all that fat will disappear. And there's also work being done in animal studies which reaffirm that. So just to go back through this spectrum, alcohol metabolism, the liver is where alcohol is metabolized. During that metabolism, it interferes with the way that the liver normally metabolizes fat. So there's an interaction between the two, and that's why we can explain that as a reproducible a situation, even in an acute setting. But then there are some that go on to this next stage, where in addition to the fat, the cells undergo the disintegration, and all these little purple dots here are inflammation around injured liver cells. And a lot of the liver cells then become ballooned. They're not distended just because of fat, they actually accumulate lots of water. And those cells are targeted to die. So this is all getting to very much a different stage of the disease, because once you get that cell death, the ballooning and inflammation, you get the scarring, and that's the scarring that lays the foundation for this a nodular transformation or cirrhosis. Now, we're not entirely sure about why it goes from this stage to this stage. We do know that for this stage, there is an association with longer-term drinking and with high levels of alcohol intake. But we also know that there are some features of our non-specific immune system and mitochondrial dysfunction that probably contribute to this. Now, an important a statistic is if you take 100 chronic alcoholics and follow them drinking very heavily, let's say for 10 years, and they're still drinking, all of them will have this fat. Only 40 of them will have the fat and inflammation. And only 20 would have actually have gone on to the cirrhosis. So there appear to be some host factors that determine this progression through the different phases. And we think that some of it may be due to dietary factors. I'll say a bit about that later. But also there's some evidence that there are some genetic factors that predispose individuals to getting the more severe ends of the spectrum, or indeed protecting. So one particular genetic factor which is well established is gender. So for some of you in the audience, for probably about half of you, this is probably bad news, but females are more susceptible to more advanced disease for equivalent amounts of alcohol intake, even if you allow for body weight and the amount of fat in the tissues. But there are also some genes that we believe probably protect, and some of my colleagues in Newcastle were always striving to find the Churchill genes. Some of you as historians might know that Churchill is reputed to have drunk a bottle of spirits a day in much of his adult life, even when he was leading us on the beaches. The Churchill gene is something that would protect. So there's this spectrum of alcoholic liver disease, but about 25 to 30 years ago, we began to realize that that spectrum was not just seen with alcohol, but was seen with some medications and some operations that were used in those days. But more importantly, over the ensuing time, increasingly aware that this is something we see in patients who are obese or who have type 2 diabetes or have both. And that whole spectrum of fat and inflammation, cirrhosis, and indeed liver cancer can be seen in that setting. So, same spectrum here. The causation here is in obesity and diabetes, particularly in diabetes, there is a thing called insulin resistance, where our cells in that condition don't really respond properly to insulin. That interferes with glucose metabolism, but also has an impact on fat metabolism, and explains, at least in part, why you might get fat in the liver in the context of type 2 diabetes. But very clearly, we do see patients with obesity and diabetes that go on to these later stages of steatohepatitis and cirrhosis. And again, though, and I'll show a photograph in a minute, there are variations, and not everyone who's morbidly obese would get by any means down to the later stages. And some of the work I did with colleagues in Newcastle has identified some gene variations that in a population there are various types of a particular gene, and two that we've been interested are here. And if you have a particular variant of that gene, you are more likely as a diabetic to go on to get the later stages of the disease. There has been some questions, though, about whether this sequence is exactly the same as in alcohol. In other words, do you go right through this sequence, or is there another way of going? In other words, some have suggested that the fatty liver disease in obesity and diabetes is either pure, simple fatty liver, or the more advanced, and it isn't sequential. And that was beginning to be a little bit of a mantra. And there have been few other studies. One study that we did, published fairly recently, was to do follow-up biopsies in a large number of patients who had non-alcoholic fatty liver disease. I'm not going to go through this in detail, but in those who had their first biopsy, which showed the fat and inflammation, and you followed them up for over 6 years, then many of them still had the same appearance down the microscope after that time. Some, however, had progressed. Some of those had progressed to cirrhosis. So if you have a biopsy which shows that fat and inflammation, there is certainly a significant risk over time in going to cirrhosis. But more interestingly, importantly, we had patients who had simple fatty liver. Some of them had just a minor degree of inflammation, not really steatohepatitis properly. And we noted that some of these, quite a sizable proportion, did go on to fat and inflammation, and some went on to quite significant scarring. So we believe very firmly that the whole spectrum, it probably is a continuum in non-alcoholic fatty liver disease. And just to give you again some ideas about the numbers, these are estimates. These are estimates based on a whole range of different studies worldwide. But if you look at the simple fatty liver disease, of those with a BMI greater than 40, 85% will have it. So not 100%, but a sizable proportion. But of lean individuals, 15%. Now, getting the more severe form, the steatohepatitis or fat and inflammation, severely obese, BMI greater than 40, still only 40%. So similar kind of message to that which we have for alcoholic liver disease. One of the very disturbing aspects of fatty liver disease is that we're beginning to see this not just in adults with long-term obesity and diabetes, but in children. Now, we've known for some time that it is something you can see in young patients who have inherited pediatric disorders of their metabolism. And these are disorders which have the same problem as type 2 diabetes of insulin resistance. But increasingly, this is being recognized in overweight children. And there are some studies in the US that say that somewhere between 3 to 5% of adolescents in the US have some form of fatty liver disease. And in fact, there are some other, mainly necropsy studies, which suggest that maybe even higher than that. And certainly something that's brought it home to me is that in the UK, I certainly saw a fair number of biopsies from adolescents that had already developed very severe scarring, and indeed some had gone on to cirrhosis, purely on the basis of this fatty liver disease associated with their obesity. Now, I mentioned a little bit about animal models earlier on when I talked about alcohol. I'm not going to dwell too much on this. This is not an area that our own group have done much on. There's a whole range of different animal models that have been designed to try and mimic non-alcoholic fatty liver disease. But I'll just give you a little bit about one which I think is interesting and has some messages for human disease. And that's the so-called ALIOS model, which is American Lifestyle-Induced Obesity Syndrome mice. And these are mice that are not allowed to exercise. And they are given a high-fat diet, but high in particular types of fat. These are trans fats that are partially hydrogenated vegetable oils, and they're found in a number of fast foods, but also in cookies, for example. They also added to it sweeteners and fructose that you get in Diet Coke, Diet Pepsi, and so on. And the animals that have the low amounts of activity, high trans fat, high fructose, get disease under the microscope looking essentially the same as human steatohepatitis. They don't get cirrhosis, but it's a pretty good model of it. So it's just saying something about our lifestyle and probably what that means for the disease in humans. Before I leave the fatty liver bit, sometimes, of course, it's not just purely alcoholic fatty liver disease or non-alcoholic fatty liver disease. The two can coexist. And I'm often asked, in looking at a liver biopsy, can I tell the difference? The answer is no under the microscope. But we know that the two are pretty much additive. So obesity is one of the risk factors for getting the more advanced stages of alcoholic liver disease. And there's lots of good evidence from epidemiological studies in the last few years of this additive effect. So the greater the BMI, the greater the risk of substantial disease. And again, animal models, this is not one of ours. There are animal models that show this synergistic effect. One of the issues for me is, what should we call this? Is it ASH and NASH? I don't know. We just describe it as fatty liver disease. And ideally, it's up to the clinicians that are looking after these patients to get a feel for what the relative contributions are from the two elements. Now, sorry if this is a bit gory, but I did want to say a little bit about how we assess fatty liver disease. And it is important to recognize that for accurate diagnosis, a liver biopsy is still probably the best thing, the best way. And this is a simple percutaneous biopsy being done. And to assess the severity under the microscope, a number of scoring systems have been developed so that the pathologist can assess how much fat, how much ballooning, how much inflammation. These are often misused, these scoring systems. They were actually designed in the first place for clinical trials. They all have inherent idiosyncrasies, and they assume a pure disease, that the patient doesn't have some other form of coexisting liver disease. I'm not going to go through this in detail at all, but this is probably the most widely used scoring system for fatty liver disease looking under the microscope. And the pathologist here scores on a scale of 0 to 3 how much fat, 0 to 3 how much inflammation, and 0 to 2 how much ballooning. And then this particular system takes those scores and adds them up. There are some inherent problems here. This is very arbitrary, the cutoff levels here. But more importantly, the bit I feel particularly passionate against is that there's an addition of all these scores when actually biologically the significance of these different components is quite different. How good are we at recognizing these down the microscope? Well, we tend to use a kappa statistic approach, which is a means by which we can say how good are we between observers or even within an individual observer at being consistent in diagnosing, let's say, scarring, inflammation or ballooning. And with ballooning, with a value of 0.5, that's moderate, it's not that good. So there are some problems with the reproducibility of some of this interpretation. And I think at the crux of this is how we assess this ballooning. Now, the cell there with just a single big white area has fat. This cell has fat and water and is ballooned, and I say that because there's still some strands of the rest of the cell present in here. And one of the problems has been knowing what we actually mean by ballooning. What are the criteria by which we say that a cell is ballooned? And there are all sorts of balloons, of course. They come in different shapes. I think, though, one of the problems is that our American counterparts have included in the definition of ballooning that these cells don't need to be bigger than their counterparts around. And that, I think, has actually confused the whole picture. And so we've argued in some papers recently that the cells inherently have to be bigger to have that diagnosis of ballooning. And we've shown that that certainly means makes for a much more consistent diagnosis of ballooning. There are some fancy stains now that we've been developing that also kind of help. But at the end of the day, I think it is about having very clear definitions. So I was very privileged to lead a consortium of pathologists from around Europe that were part of a European Union funded multi-center program, not just looking at the pathology, but looking at fatty liver disease in general, including treatment protocols and so on. But the group that I chaired was very much around developing new ways of describing this and moving away from adding those figures up that the American system has done and having much more of a profile, a consistent approach to it, which is proving to be very valuable in clinical studies, but also in larger epidemiological trials. I'm going to spend the rest of the time talking about liver scarring. Because, as I said earlier, this is a final common pathway in pretty much all forms of chronic liver disease. And I've already alluded to this, but whenever you get liver injury, you get liver inflammation, and that generates the scarring, or it leads to the scarring, and that can go on to cirrhosis. Now, when I was training with Sir Roddy, at that time, liver scarring was actually thought to be a passive phenomenon. In other words, the liver's framework was thought to just collapse whenever the liver was injured. But this is Hans Popper, the doyen of hepatology, and I was privileged to have met him on a number of occasions, a really bright, influential guy. And he really said, no, this is a dynamic process, this is not static. This is not collapse, this is an ongoing thing, and it's caused by a net accumulation of some of our framework proteins in the liver, but they're then there in the wrong amount, the wrong distribution. But also he began to explore, it wasn't necessarily static and it was there forever, but actually it's potentially reversible. And we now believe that cirrhosis, under the right circumstances, can be reversible. And the whole process of liver scarring is very similar to scarring in the skin. And so we know an awful lot about wound healing in the skin because it's very easy to study. And we know that injury of the skin, you get damage to the epithelium, and the repair process generates inflammation, a whole range of chemical signals that lead to regeneration of the cells that are still around, but also stimulate some of the fibroblasts, and these are the cells that produce that surrounding framework. And in a normal situation where it's a single injury, an acute injury, then this actually goes round nice full circle so that you go back with the regeneration to completely normal skin and normal dermis. However, if there's a chronic injury, then the focus is much more on the scarring bit rather than the regeneration. And you end up replacing the normal tissue with scar tissue, which is less functional. So essentially the same is true in the liver. But when I was in training, we didn't know what the fibroblast equivalent in the liver was. And I somewhat serendipitously discovered that these cells, at least in animal livers, express a protein called desmin, which is normally in our muscle cells. And by this, we were then able to demonstrate the number of these cells in an organ and show whether they increased in response to injury or they decreased. And we also were able to show that, that not only we could demonstrate their number, but other phenotypic, other changes in their profile in response to injury. And so we demonstrated that these cells, now called the hepatic stellate cells, are the liver's fibroblasts. They're not quite like the fibroblasts we have in skin, but in response to liver cell death and inflammation, they proliferate, they increase in number because they're dividing. And they're stimulated to do that because of some of the signals from the injured liver. But we also showed that that wasn't just true in animal models, it was true in human disease, and we did a large series looking at patients who'd had a biopsy having recovered from paracetamol overdose. Again, a study you probably wouldn't get away with nowadays in terms of that. It was an archival a set of biopsies. But it showed that it was exactly the same in humans as it was in the animal models. But that's transient and in an acute disease, and after a while, those cells disappear. But in chronic disease, such as chronic fatty liver disease, these cells persist and indeed continue to expand in number. And the paradigm now is that these cells in the normal liver are so-called quiescent. They're actually the cells in our body that store all of our vitamin A. And so the only time you can really identify these easily under the microscope without the fancy stains I used is if someone's been eating polar bear liver, because that's very rich in vitamin A and it lights these cells up. That's not a common occurrence. I haven't seen many biopsies like that. But anyway, these cells contain vitamin A as liver, as fat droplets. But in response to chemical signals because of cell death, and some proteins released from these injured cells, and a number of other immune responses, they proliferate, they lose the vitamin A, and they lay down lots of collagen, which is a type of protein we have in our skin and a framework for the liver. And they call those activated cells. Now, this is a complicated slide, but really just to say that one of the things that I was very excited about in my time in Brussels with Bert Geertz was the ability to develop a model by which we could isolate these stellate cells from animal and human liver, grow them in culture, and then look at what were these signals that were switching the cells on. What was telling those cells to proliferate and to become more like an activated fibroblast and produce all the scar tissue. And over the ensuing years, my own group and a number of large international groups have identified a whole host of inherent chemicals. They're called chemokines and cytokines, and they're often from inflammatory cells. But these bind to the surface of the stellate cells and send signals to their genetic makeup, which tells those cells to produce more collagen or to proliferate. And the importance of this, of course, is that this is a means by which we can identify new potential treatments. And of interest to us in Newcastle was that among the things that we recognized that was switching on these cells were things that we knew a lot about from other organs, like from the kidney, the so-called renin-angiotensin system, and serotonin, which is a chemical mediator in the brain. And again, what's really interesting and important is that there are already treatments that we use in other settings that inhibit the renin-angiotensin system or inhibit serotonin that can be used in clinical trials. And these have now been adopted in practice, or at least in clinical trials, in fatty liver disease. But all the information about the various different mechanisms of scarring in the liver has led to a proliferation of studies looking for new, safe magic bullets. So looking for things that would target some of that list of chemokines and cytokines like TGF-beta. It doesn't really matter what that is, but these are all things that are under development at the moment. Quite a lot of money going into this from drug companies, particularly in the US. Now, I want to say just a little bit in the last few minutes about more applied studies that I've been involved in liver scarring. Assessing fibrosis, again, it's widely regarded that probably still the best approach to this is a liver biopsy. It's often been talked of as the gold standard. And again, we use some of these semi-quantitative scoring systems that I described earlier. But there are sampling problems. We know, for example, that a tiny liver biopsy is 1/50,000th of the entire amount of a liver. So there is great capacity just to be getting, and the liver scarring is not uniform throughout. We also know that, as I described with the ballooning, we don't always get it right. If two pathologists look at it, we don't always agree, so there are some reproducibility issues. But more importantly, a liver biopsy is an invasive procedure. It can be painful, there can be complications, and occasionally, I have to say, there are deaths from liver biopsies. So we should be exploring other ways of assessing fibrosis. And I don't think it's a gold standard anymore. It's at best a silver standard. So there's a number of different approaches have been developed worldwide. Some use imaging, like ultrasound, and a particularly interesting one is transient elastography, which is basically a scanning device put over the surface of the skin, which looks at the liver stiffness. And if it's more stiff, then it's more likely to be cirrhotic. That's a great approach, but there is a limitation because the actual scanning procedure doesn't really work in the face of obesity. So that is a limitation when it comes to non-alcoholic fatty liver disease. And so it's got some other limitations. So one of the areas I've been particularly proud to be part of is the development of alternative approaches using blood tests. These are so-called surrogate markers of liver scarring or liver fibrosis. The very first of these to be described was not in fatty liver disease, but described by a famous French hepatologist who marketed this fibro test amazingly across Europe, the proceeds of which he bought 3 Michelin-starred restaurants in Paris, so he's done particularly well out of it. We've been involved in similar studies. I don't have a Michelin-star restaurant. But we did some studies with people at the Mayo Clinic developing an algorithm which actually utilized clinical information, age, gender, but also blood measurements of platelets, certain blood cells, and so on. And that's actually quite useful in practice, but the one I was particularly excited about being part of is the ELF study, and ELF stands for European Liver Fibrosis Group study. And that was a study by which we looked at blood measurements of a range of different proteins that come from scar tissue. So what we're looking to do was to see how those algorithms of those measurements compared with what I was looking at down the microscope in thousands of liver biopsies. And that is a test which has shown to be quite useful in clinical practice. But one of the criticisms of this has been that, well, all you're doing is still using the liver biopsy, which was I was interpreting as the gold standard, and testing these algorithms against it. What's really pleasing to see is subsequently we've looked at this in how good is this test without liver biopsy in predicting liver-related health outcomes. And the bottom line is, and in a way it's a bit sad to say as a pathologist, we could probably do without liver biopsies now in this, because this is as good a predictor of outcome as the liver biopsy approach that I've been used to over all these years. And so a lot of interest in whether we might be able to use this as a screening technique. It's a simple blood test, and there are now a number of variations upon a theme. It's not being used yet in clinical screening procedures, but it might well be. So I have a few take-home messages. Fatty liver diseases are a major cause of morbidity, of illness and death. They are diseases of excess or overindulgence. There are some causes of fatty liver disease, I should point out, are not due to excess alcohol or being obese or having type 2 diabetes, but the bulk of them are. The extent of the public health problem of non-alcoholic liver disease, fatty liver disease, is still not entirely clear, and that's partly because of the issue around the definitions that I alluded to earlier. And understanding the basic mechanism of liver scarring has been useful in identifying new, less invasive diagnostic tests and leading to new, potentially exciting treatments. And then the other take-home message is remember and love your liver and everything in moderation. I would like to just finish with a few acknowledgements. I've already talked about Surrogate, Eddie Wisse and Bert Geertz in Belgium, but also the team that I worked with over a number of years in Newcastle and some collaborators in London. MacArthur is now the provost of UCL in London. And above all, my family and my wife Alison is in the audience tonight. Thank them for all the support in all the endeavours in this over a number of years. Thank you for your attention.
Happy to take questions.
Yeah, for sure.
Well, Alastair is happy to take some questions. So, questions from the audience, please.
I would like to know if there's any viruses that can cause liver disease.
Yes.
That has cirrhosis in the end.
Yes, so in fact, worldwide, viruses still are the most important cause of chronic liver disease. And the two important ones there are hepatitis B and hepatitis C. And particularly if you look at Southeast Asia, hepatitis B has been a major problem for a long time. Fortunately, there are now some immunization programs which is showing a reversal in that, and the number of cases now of hepatitis B in Southeast Asia is certainly on the decline. Hepatitis C is a disease which was initially described in patients who'd got it from infected blood products. In most parts of the world, that's most commonly seen now in intravenous drug abusers. So hepatitis B and C are both seen in Australia. They are both, and with hepatitis C, again, you can go right through to cirrhosis. And there are millions of patients around the world with both of those viruses. But interestingly, with hepatitis C in particular, there are some new treatments that have been described in the last 2 years that are absolutely phenomenal and are going to blow that disease away, I'm quite convinced, over a number of maybe 5 years or so. And I think the real concern for the next little while would be the rise in fatty liver diseases, both alcohol and non-alcoholic.
Is there a relationship between alcoholic liver disease and pancreatitis? And if there is there a relationship between fatty liver disease and pancreatitis?
So,
fatty liver disease with other causes.
Yeah. So alcohol excess can cause both the liver disease, the fatty liver disease, and chronic pancreatitis. Chronic pancreatitis of the sort that we see with alcohol is not something we see in non-alcoholic fatty liver disease. There are changes in the pancreas, but that's related to the diabetes. But interestingly, with the alcoholic situation, there seems to be a reciprocal relationship. In other words, it's rare to have a patient who has pancreatic disease as well as liver disease for reasons that we're just not at all sure about. Those are old observations, but I've not seen anything to suggest that that's still not the case.
I have a similar question about hepatitis C. Most baby boomers are probably positive due to transfusions and certain activities of their free lifestyle. On the other hand, children should be negative for Hep C as well as alcoholic fatty liver, so they could be a good control group.
So there are big centres that have paediatric liver experts, and they have been involved in some of that sort of case control type of work. The point you made, I did give reference to the fact that hepatitis C was often due to intravenous drug abuse. It's important to recognize that there is a significant number in many countries of patients with Hep C which we just don't know how they got it. They weren't involved in intravenous drug abuse. In some countries, it emerges that was possibly they got it because of immunization procedures. So there's very good evidence in Egypt, for example, it's not immunization, but treatment of a worm, a parasite that occurs there called schistosomiasis, used to be done in clinics where a number of patients would be seen at one time. And rather than using a separate needle, it was used for a number of different patients. So the incidence of, prevalence of Hep C in Egypt is quite high because of that. And we suspect that may be also the cause of sporadic hepatitis C in other countries, including Italy, where actually that's quite high. But the pediatric and looking at children is a really important one.
Thank you, Professor Burt, for an excellent lecture. Is there any connection between scleroderma and the excess collagen produced in the liver by vitamin A?
No, not that I'm aware of. Scleroderma is a chronic disorder, an autoimmune disorder, and there are some liver diseases, one in particular called a primary biliary cirrhosis, something that I actually have spent some time studying with Sir Roddy many years ago. And so there is a relationship. Patients with scleroderma are at a higher risk of getting, there's a relationship between the two, but not a relationship with fat in the liver, not to my knowledge.
You said that study of the medical students, if they stop drinking, then the fatty liver goes away.
Yes.
I lost 45 kilos 15 years ago, and I've still got a fatty liver. And I'm a vegetarian, and I don't have very much saturated fat or trans fat in my diet.
So I did want to finish by saying it's not always excess, because I envisage that there would be people in the audience that might raise that as an issue. So in some situations we just do not know what is the cause of that. I would say that, interestingly, at the other end of the spectrum, we've known for a long time, I'm not suggesting that you're starving, but that starvation also causes fat accumulation in the liver. So it's actually at the two ends of the spectrum there. So you'll see pictures of children with dietary deficiencies in areas of famine, for example, and they have a large stomach. And that large stomach is because of a large liver, because it's full of fat. And the mechanisms are quite different. I'm not for a minute suggesting that's something that is common actually here. It does occur occasionally in anorexia, but there are some cases where we just don't quite know what's causing it.
You mentioned about looking after one's liver. I presume an important way of doing that is good diet. Are the food pyramid type guidelines still relevant, or should they be updated? Sorry, should the food pyramid guidelines, the ones that we're used to with having enough fibrous materials such as bread, or good quality bread, plenty of fruit and vegetables, minimal salt, minimal butter, those sorts of things?
Well, yes, I mean, those sorts of nutritional guidelines are not my area of expertise, but I think I'll just come back to my very last slide about everything in moderation. There's lots of studies pointing to different formats of diet that will be good for you or not so good for you. I think it is about doing things in moderation. And I think that that also includes some moderate exercise, because it isn't just that a sedentary lifestyle undoubtedly contributes to non-alcoholic fatty liver disease.
Thank you for a very informative presentation. I know you touched on paracetamol, but I just wanted to know if there is a role that pharmaceuticals or prescribed medication plays with fatty liver disease.
You mean over-the-counter medications?
Yeah,
so
exactly.
the paracetamol, I was in there because that was not fatty liver disease, but that was about a mechanism. It was about these cells responding to injury. So the reason we were interested in paracetamol there is it's if you have a paracetamol overdose, the patient either has such a big overdose and they die of liver failure, or it's not such a big overdose and they recover. Of course, some get transplanted, but those who recover, it's because of the liver's phenomenal reparative processes, but as part of that, these cells get switched on. So I was using that. So as far as say, over-the-counter preparations and fatty liver disease is concerned, I'm not sure there's a major role there. But there is, in terms of medications, there are some medications in common use that we still recognize as causes of fat and the further, there's some cardiac drugs, for example, that can show that whole spectrum. But in the big picture, those are relatively insignificant compared to the rest of the fatty liver diseases.
Thank you very much for your presentation. It's been very good. I was wondering about liver cleansing diets. Have they had any impact?
I'm not sure. I have one of my colleagues who was a pathologist in Christchurch. He contributed to one of the books about liver cleansing. He's an advocate. I'm not sure how strong the scientific evidence is. It's not something I've delved into much. He believes in it, but I can't really comment.
Thank you, Professor Burt. I'm a psychiatrist, and we, over the last 25 years, have been handing out a lot of serotonin, selective serotonin reuptake inhibitors. Is that related at all to what you mentioned about what was happening with serotonin in the liver?
It's the same sort of idea, but it's not. I don't think there's any concern at all about those treatments that have been used for many years and the risk of any liver disease. There's no evidence for that I'm aware of. But this is actually a slightly different take on serotonin, and it's different receptors that we're interested in. So the receptors that are expressed by these cells are quite different from the receptors that are in the brain. But it is just a potential additional target. I mean, we've got evidence. We've got a sort of experimental drug which looks as though it could do the business in terms of slowing down the amount of scarring. But that's quite different from the SSRIs.
Okay, perhaps we'll leave the questions there. Thank you. Alastair, thank you so much for a wonderful talk. It was fascinating to hear of how you came into the field, and really interesting to hear about your mentors, and then, of course, to hear about the science associated with the liver and the latest treatments. Now, I have a gift here for you, and I'm really hesitant to present it to you. But I'll go ahead in any case. Now, recommended dosage, 1 teaspoon per evening. Thank you so much.
Thank you very much. Thank you.
Well done.